Very interesting case. This is not very uncommon to see women with polycystic ovarian syndrome who cannot be stimulated adequately, and when stimulation tends to fail. And that's because of a very different reasons. And where are the two challenges? Challenge number one is those with poor responders, where it is difficult to stimulate ovaries that have a low egg count, to going to the other spectra where you're finding it difficult to stimulate ovaries with a high follicle count. So I'm going to share a screen, and we'll be able to explain how this functions. So let's look at this case. A 35-year-old lady with primary infertility, oligospermia, PCOS, irregular periods, an FSH of 4.6, LH 12.5, AMH of 47.5 p-molar liter, large volume ovaries. She had a first cycle elsewhere where she was started a dose of 150 and 2 follicles started growing, and the cycle was abandoned. So then we started and we said, well, let's try and double the dose. Again, these were ovaries with a large thecal component. So we said, why don't we use recombinant? Now, if you have looked at all the evidence, what is a better drug? Usually HMG seems to be a better drug, even with PCOS. One is because it prevents a massive over-response. And secondly, it seems that better quality blastocysts may be created, but that's very debatable. So here we started with a dose of 300. And by day 11, again, 2 follicles were recruited. And again, we had to abandon this treatment. So the cycle was abandoned. The patient was asked to continue metformin and minocytol, that's Inofolic. In that period, both had COVID, and 4 weeks later, the sperm count dropped to less than 0.1 million, and the follicle count was between 20 and 25. So we waited for 3 months, and the sperm count then reached 2.5 million. So what does it tell us? And there's not good evidence to suggest that if you have a COVID infection, sperm counts may be influenced. And there's also some evidence coming that the antral follicle count may vary, but that's a different discussion. But sperm counts are known to decline. And we waited 3 months, and the sperm count was back to pre-COVID levels. So what we do this time we started with Gonal-f at 415, and that's very rare. I would recommend that you don't start it on this dose. And we saw a good follicular growth. So what have we learned here? We learned here that this is a metabolic PCOS, where stimulation of the ovaries has been incredibly difficult with 150, 300. And we have failed to break the FSH threshold. So we concluded that this treatment with a lot of follicles, we give a Bisserlin trigger. I tend to give 2 triggers of 1 hour apart. Oocyte collection, 23 oocyte obtained, ICSI 13 fertilized, and 6 blastocysts have been frozen. Post-egg collection, there is good evidence that if you add antagonist and cabergoline, even with an analog trigger, your ovaries settle down faster, and women tend to have a period much faster. And I've presented this in one of my earlier talks too. So let's go back to the triangle. Now, what do you look at a triangle? You look at things that form the AMH, and these are the small follicles. So the higher the AMH tells you about resistance and the difficulty in recruiting follicles. If a high AMH is accompanied by irregular periods, that makes stimulation difficult, and remember that. That's a key indicator that follicular growth has been hampered. Now, what are your resistance markers? And I'll say, I believe this triangle helps me to understand it. And the resistance markers, which means that they're pushing from the follicles to grow, are high volume ovaries, high AMH, irregular periods, high LH and androgens, small size follicles. These follicles are very small size. very, very difficult to stimulate, and increased BMI. So what breaks the threshold? The dose of your FSH. FSH given at what dose that breaks the threshold. The growth is depending on, again, the dose of FSH. So to break that threshold, know what you're going against. You're going against your resistance markers. So think about it and look at your resistance markers. Document those. Is the volume high? Is the AMH high? Is the periods irregular? And irregular periods is the hallmark of failure of follicular recruitment due to insulin resistance. High LH androgen, small size follicles, increased BMI, and then plan the dose. Remember, you can reduce insulin resistance by insulin sensitizers such as metformin. So learning points, again, high resistance ovaries, understand your ovary. Always start low, but remember, in PCOS, which are metabolic, you may need to up the dose higher, and that comes with complications. Also remember that metabolic PCOS, women with irregular periods, with high LH, high AMH, may also have many immature eggs and may have a poor conversion to a blastocyst stage. So that is, in short, about PCOS, which is metabolic. And I'm sure that many of you all will see cases like these, which are challenging and which, in fact, are very distressing, because some patients will produce 2 or 3, and someone taking a step back and saying, let me push the ovary harder, may give you a better chance. So again, if you follow me here, there'll be talks on YouTube and Facebook, but on Instagram, you'll see daily talks coming up under fertility education, and you're more than happy to subscribe to that. Thank you.